challenging cases from the Cath lab.
So, good morning, dear colleagues. I'm very happy to join this German-Vietnamese symposium, which is the first for me to do an online presentation. So I hope everything will work correctly in the technical mode. And I will share my screen with you now. So, what is that? Ah, here, okay. So now we have the PowerPoint presentation. Can you see the presentation?
Okay, I hear you.
Can you see? Okay, so
Yeah,
I will start. My topic is to talk about acute coronary syndrome and especially STEMI patients and the treatment in the Cath lab. And I have 4 cases, I've chosen 4 cases for you to discuss some aspects of this topic. So the first case is from the medical point, not very complicated. Is a man, 56 years old. He's working in Wolfsburg in the Volkswagen factory. This is a very big factory, about 30,000 workers there, and they have their own medical system and emergency system and everything. And this man, he went to work at 6 o'clock in the morning, and soon after he started working, he experienced severe chest pain. So he went to the emergency department, which is in the factory area, and they have their own ambulance, which arrived quickly, and they did an ECG. As you can see, the times, it took about 15 minutes from when he arrived at the emergency department to the ECG. And here you can see the ECG, which shows you a large inferior myocardial infarction with a huge ST segment elevation in 2-3 VF and even in the lateral planes. So we can say we have a very big inferior infarction in this case. And the patient was put into the ambulance car and brought to the Cath lab. And that is what we found. We find the right coronary artery proximally occluded. Is quite a big artery, as you can see, and the left coronary artery has no severe atherosclerotic disease, but there are no collaterals from left to right. So it's crucial for the myocardial salvage of the patient to get the right coronary artery open quickly, and that's what we did. We have a wire through here, and now we see, you can see the white material in here. So there's an atherosclerotic lesion and some large thrombus here. So we decided to do thrombus aspiration, which we do not routinely. And we got out some red thrombus in this patient. And I would like to discuss this aspect of the case because the routine use of thrombus aspiration is not recommended in our guidelines. But the guidelines state, and you must know, that in certain cases with a large thrombus burden, as mentioned here in the text, there's even a difference in cardiovascular death if you are able to remove the thrombus. So you should choose individually whether you do that or not. And this is what the guideline says. In case of large thrombus burden, thrombus aspiration may be considered. And so we did it in this case, and we had a good result after stent implantation. There's some residual thrombus here. We did not do any further dilatation because we were fearing that we could compromise the flow to these right ventricular branches, which are open but occluded proximally. So we stopped the procedure here, and we had level cardiography. We had large inferior hypokinesia, which, as we know from echocardiography, some days later resolved, not completely, but the LV function got better in the following days. We had high CK in the initial examination as marker of myocardial damage, but the CK got down very quickly, and so the left ventricular function could be not preserved, but ameliorated. So I want to draw the attention of your want to draw your attention to the organization of this case. He had beginning of symptoms 10 minutes before 7, and he had the artery open in 10 minutes after 8. So this is 1 hour and 20 minutes. And this can only be achieved if you have a good attention not only to the Cath lab procedure itself, but also to the logistics around. So you have to know, you must recognize the symptoms as early as possible, which was good in this case because this man went to train personnel in the emergency department of the Volkswagen factory. And they did right, they registered the ECG immediately, which is very important to get the diagnosis. And after that, they started to call the hospital and tell us, we have a patient here, we'll come to you to be treated. And this is very important because this means that the hospital can prepare for the case. The Cath lab team can be activated and the interventional doctor can come in if it's outside working hours, and all is ready when the patient comes. And when the patient comes, he's not going to the emergency department, and unless he's not hemodynamically unstable, he's also not going to the emergency department, but directly to the Cath lab. And these logistic points are very crucial to have a good medical result. Logistic optimization, additionally to optimization of the procedure in the Cath lab. And this is a very important message I want to give to you, and this is why I showed you this case. My next case is a 96-year-old man. He had chest pain in the early morning and nearly in the night. And he did not call the ambulance, but he went to his family doctor. So this means he lost a lot of time, maybe 3 or 4 hours. And the first ECG the family doctor recorded was about 11 o'clock in the morning and showed right bundle branch block and tachycardia, and also a ST segment elevation. I will show you the ECG soon. And this is why the family doctor called the ambulance, and the patient was brought to the hospital, and he arrived short before noon. He had chest pain since some days, but not so severe before. Only the day of admission was very severe, and he had risk profile, but no significant cardiovascular disease before. And this is the ECG. So the ECG shows tachycardia. We have a complete right bundle branch block, and we have very extensive ST segment elevation here in the inferior leads and also in the lateral leads. So we might suspect we could have lateral myocardial infarction in this case, but maybe it's a big infarction because of the extent of the ST segment elevation. And we are not sure whether we have some anterior problem also, because we don't know whether the right bundle branch block is new or was known before. We don't know this. So we brought this patient to the Cath lab, and still when he arrived, it's not really good hemodynamically. The tachycardia is less now, 80 only, not 115 as before, but the blood pressure is low, and we start the coronary angiography, looking for the right coronary artery, which you can see here is a normal sized artery, no severe atherosclerotic disease. And we can not really see collaterals to the left side. So we are not sure what we have to expect when we go to the left. And here we can see the first shot to the left coronary artery. And as we suspected, we find occlusion of the circumflex artery. We must keep in mind that at that moment, maybe it was 5 or 6 hours from onset of symptoms, that this artery is occluded. And we see another problem. We have high proximal LAD stenosis here, and LAD perfusion is timely, it's a TIMI3 flow, but this is a very severe stenosis. So what should we do with this situation? We have one occluded artery, but already probably a damage in this area, and another artery which is clearly prognostically relevant and really dangerous. So what shall we do now? We started to put wire in, and this was by chance that the wire ran into the LAD and here in the diagonal branch, but we were happy about this because it gave us more safety for this lesion, and we still have TIMI3 flow in the LAD area, so this is reassuring. So we have a good start with a little bit luck, but we did want to wire both arteries intentionally. So it was not very difficult to get through the circumflex occlusion. We have a high-grade lesion now, but we have flow, not TIMI3, but TIMI2. We can see the course of the artery. We can see the short stenosis, not much thrombus, so no thrombus aspiration required. And as such lesions frequently consist of soft plaque, we decided to go for direct stent implantation. And here we place the stent and we open the stent, and we have a quite good result. So what should we do now? Should we go for this additional stenosis in the circumflex territory, here posterolateral, the other posterolateral, or here? Or should we go for this lesion, or should we leave it and do it in another procedure? It's really difficult to decide now how to continue. And we discussed in our group what to do. And we decided not to go for all these bifurcations here regarding that the symptoms were for many hours already, and we had TIMI3 flow in all arteries, and would have taken a lot of contrast and everything to get this fine. And so we decided we had finished the circumflex territory for now, and we decided to go on for the LAD territory. And also here we decided to go for direct stenting, and we placed the stent, and as you see, we had not much time to put the stent. We had to be very quick because we have no flow now, and we had to adjust to not compromise the left main bifurcation, and we quickly opened the stent, and after that we had nice flow in the LAD territory, and we checked in different projections where territory is maybe slightly hyperkinetic, but not much, especially septally contraction is rather normal. So this patient had initial CK, even blood taken before start of the angiography, very high. So the myocardial infarction already was ongoing for some hours. This meant that the akinesia in the inferior and lateral part of the heart did not resolve. We had a scar there some days later, but the global function improved slightly, and we were content. So we have to discuss, should we have done the LAD procedure in the same session, or should we have done this separately? And we have our guidelines of 2017 for the myocardial infarction treatment, and they say non-infarct related artery PCI should be considered, we should do in patients with cardiogenic shock. This was not a very frank cardiogenic shock, but the patient was not well doing hemodynamically, and the prognostic relevance of the LAD lesion is quite clear. So we decided to do that as recommended in these guidelines. But 1 year later, we have new guidelines on myocardial infarction. And in the meantime, the culprit shock study had been published. And in this study, has been shown that immediate doing of non-infarct related artery leads to a higher 30-day mortality than if you defer it. So, and it leads to more frequent renal function deterioration. So in the next guideline, only 1 year later, they say it's not recommended to do that. So it's a really difficult decision. If you have the acute case, what will you do? Will you stop and go for a second procedure some days later, or will you do it? And my personal view of this is, in the actual case, we did right. because we could do that. We had the wire in, and we could expect to have it done with little contrast, additional contrast media need, and with little risk of compromise in the LAD territory. If we had risk to damage the LAD, or if we had a bifurcation, or if we had large thrombus or much arteriosclerosis, much calcification, if it would have been a very complicated procedure, maybe we would have better decided not to do it in the same procedure, but later, for safety reason for the patient. So this is an aspect we can discuss later. What would our colleagues have done in a case like this? I move on to the next case. We have a 76-year-old man who has chest pain on low-level exertion since 1 or 2 weeks. And when he comes to the hospital, he has atrial fibrillation, but not hemodynamically critical. It's a normal heart rate. And he has ST segment depression anteriorly, not no ST segment elevation. So it's not STEMI. We have a little bit of time. So we made echocardiography, we found normal function and no valvular disease, which was important also because we had at auscultation found a systolic murmur. But as he had this ST segment depression and elevated troponin and known coronary disease and vascular dystrophy and peripheral arterial disease, we decided to do the procedure on the same day, 1 or 2 hours after hospital admission. And this is what we found. We found normal left ventricular function. We have a lot of calcification in the mitral annulus. We have also calcification in the aortic root and proximal left coronary artery and nearly all the way down the right coronary artery. So we expect to find rather severe coronary disease, and we start with the right coronary artery, and surprisingly we find calcification but no high-grade stenosis. So we do the left coronary artery, and now we can go home. We have no stenosis. Do you agree? Yeah, little surprise, we have to do more projections. It's always crucial to get projections to have every bifurcation and every part of the artery really free sight on. And the next projection shows the problem. We have high-grade proximal ostial circumflex lesion. And if we go on to analyze this, we see we have atherosclerosis in the left main and also in the proximal LID, but not high-grade, and this ostial circumflex stenosis. So if we go on now for the treatment of this, we have to be aware that it can come to a left main bifurcation intervention with maybe 2 wires and 2 stents and kissing and everything. So we prepare for that. This means we use a bigger guiding catheter. In this case, we use 7 French normally, and we wire both vessels, of course. And but we decided, as you can see, it's quite a rectangular origin of the circumflex here, that we would try to do this in a 1-stent procedure in a T-stent technique. So this is what we did. We have the wire in, which was surprisingly easy for the circumflex, but it looked difficult to get in here, but it was not really difficult. So we have 2 wires now, and then we predilate the circumflex ostial lesion, and we have a little less stenosis and no damage to left main and LAD, which is very important. So we can continue with our strategy of 1-stent T-stenting. And what we decided to do here is to put a balloon in the left main to LAD and the stent here in order to preserve the bifurcation and not to damage the bifurcation and not to cause a plaque shift in the direction of LAD during the inflation. And you can see we place it we can place it in both planes quite exactly. And then we do a kissing inflation of both the stent and the balloon. And after that, we have a good result and no damage to LAD and to left main. And we checked this in different projections, and we are quite happy with the result. We can stop the procedure here, and we were lucky that we don't have to do a complex left main bifurcation intervention in this case. My last case is a 60-year-old man coming to the hospital in the morning. He had severe chest pain on that day, but he had chest pain since a long time already. He's a former smoker, but long ago, and he has peripheral arterial disease, and he's obese. He's rather young. So he comes to the hospital at early, not early, 8:30 in the morning, and he has he called the ambulance to come here, and this is the ambulance ECG, which was sent to our hospital. And what we can see is deep ST segment depression in nearly all extremity leads, and ST segment elevation in VR. So this is not 12 lead, but when he was in the hospital, we have 12 lead. It's a little bit better now, not so deep ST segment depression, but the same picture. We have isolated ST segment elevation in VR and ST segment depression predominantly in the lateral area. So what does it mean? Is it STEMI? It's not STEMI, of course, because definition requires 2 adjacent leads with ST segment elevation, but for only 1 lead. But we have to keep in mind that ST segment elevation in lead VR can be very critical, can be signaling that we have ischemia in nearly all of the left ventricle, which is frequently associated with left main disease. So if we have isolated ST segment elevation in VR and ST segment elevation nearly everywhere else, we should be very alarmed. And this is what gave us the decision to go to the Cath lab rapidly. And also this patient was not very fine hemodynamically. Also clinically, he was sweating, he had vegetative symptoms, he was not fine. And angina also, so we started to do the diagnostics, and we found a stenosis in the right coronary artery, but we have to look closely. What we see is a lot of collaterals to the left system, and you see the calcification near the ostium of the left, and in the other plane, we can confirm this. We have the right coronary artery high-grade stenosis, and we see collaterals, and we see a lot of calcification at the left main ostial area. So we do the injection of the left coronary artery, and we are prepared to find some serious thing, and we are surprised it's more serious even as we thought. We have a subtotal lesion in the left main, and during this injection, it took only maybe 20 seconds to have the catheter here and do the injection. The patient went rapidly worse. The blood pressure got down, and he was threatening to go into cardiogenic shock. And as you see, I can remove the diagnostic catheter immediately. And after some catecholamine bolus, the situation stabilized. So what can we do? Should we do this with coronary intervention? We have a right coronary artery with a high-grade stenosis. We have the problem if we go in here with any kind of catheter, the patient will get unstable hemodynamically. And we have probably thrombus or atherosclerotic debris in a large amount here. Then we have the circumflex ostium. We cannot even see where to wire the circumflex ostium. It's a long stenosis, proximal circumflex, and we have another stenosis here. So in this case, we decided not to dare this, to treat this interventionally. We did left ventricle, which is surprisingly normal. After the coronary angiography, we got laboratory results. The CK was also normal at that time. And so we decided to transfer this patient to a surgical center. We don't have cardiac surgery in our hospital, so we have to move the patient to another city, even 30 kilometers. So we called them and we organized the transport, and he went to the adjacent hospital in Braunschweig, where he was operated in the afternoon, and he could receive complete arterial revascularization, which is really good, with Lima artery and radial artery. And so he's a young man and he has complete arterial revascularization, and the operation was uneventful, and he left hospital without major damage at his heart and in good health. So this comes back to the first patient I mentioned to you. You have not only to do good interventions, you also have to have a good organization. In this case, we had to have the good contact to the Braunschweig hospital and to talk to our colleagues to help us with the patient. So they took him and they treated him, and we were very happy that we got a good result for the patient. And the guidelines state that CABG should be considered in patients with ongoing ischemia, large area of jeopardized myocardium, if PCI cannot be performed. Whether it would not have been possible, I don't know, but it would have been very dangerous in this case, and I'm content that we decided for operation. Thank you for your attention, and maybe we can discuss the case.
Thank you, Dr. FLEISCHMANN. That was very spectacular cases in the Cath lab. Professor Zinning, is he online? Professor Zinning? Is he online?
No.
Okay, we have no questions now, and for time reasons, I want to introduce the next speaker. This is Dr. Birgit Gericke, and she's speaking about pharmacological heart failure therapy, an update in 2021. So, dear Birgit, how are you?
Mikrofon anschalten.
Yeah, please turn on your microphone.
Okay, I'm not in the meeting. It tells me.
Open your microphone. Okay. We hear you now.
But do you see my?
I saw you, but not your slide.
So where are my slides?
Bildschirm freigeben.
Okay, yes.
Doch, der Bildschirm von ihr wird freigegeben.
Ja, neue Freigabe. Desktop.
Muss hier sehen.
Can the technician help me?
Now, here.